Look at the medical assessment of the patient. We've already walked through the size up, the ABCs, the primary assessment. So this gets more focused in on as you're starting to narrow the patient assessment down. Remember on your skill sheets, at the first few blocks of that's what we did the other day, almost in the chapter. This is the next big section as it goes through that skill sheet. And if you look at your skill sheet and you look at this, you can sort of see the way that it goes. They talk about patient assessment on a responsive and unresponsive patient. Obviously, an unresponsive patient, someone that's unconscious, the assessment is going to have to be much quicker, right? Because there's something wrong for that patient to be unconscious. So that's what you want to find out really quick. What sort of life-threatening ordeal do we have there that the patient is unresponsive for? A responsive medical patient, you have quite a bit more time, or you have an additional time. Not necessarily in trauma. Trauma, we know that the standard of care is essentially 10 minutes to transport. So in trauma, you would do most of your assessment en route. That's part of your skill sheet as well. Your medical assessment, you might be able to stay on scene a little bit longer. So we look at it on a responsive patient that sort of goes down through the sample. You get a history, a past medical history. You focus in on the physical exam. So if they're having chest pain, there's no reason to focus in down on the feet. You still look at the feet, you still check distal pulses, and you do that. But when it's a focused physical exam, you focus more on what the problem is, what the chief complaint is. And then always get a baseline set of vital signs in both of them. So we look what the present illness is. A conscious patient, we're fortunate enough perhaps to get this information from the patient. If not, then family members and bystanders, maybe we can get some information from them. This says ask open-ended questions, but I disagree with that. I always try to ask closed-ended questions. That way you don't get a huge response from them. When you're trying to figure out what the problem is with any problem, you want as little input as possible that's extra. Now you want pertinent information, but a lot of people, they don't answer directly anymore. They answer in these big, huge sort of circles. So I always try to ask closed-ended questions. Are you having any chest pain? Do you have a cardiac history? Do you have any respiratory problems, such as emphysema, CHF, asthma? All right? Do you have diabetes? Do you have seizures? You know, big questions there. And then once they say sort of no or yes to all that, if they say yes, then you can tunnel in. Say if they say they have a cardiac history, then you can sort of focus in on that. Okay, well, what happened? Did you have a heart attack? Yes, I had a heart attack. When was it? So you're asking closed-ended questions, and you get shorter responses. And that lengthens the amount of time that you're going to spend here trying to figure out what's wrong. Once you figure out what's wrong, then you can go back and gather more information. But right now, we're just sort of trying to figure out what's wrong with the patient. So I always say closed-ended questions, because if you ask somebody that's 99 years old if they have any medical problems, right? You get it back from the early 1900s, correct? Oh yeah, back in 1901, I had my appendix taken out. Something in this century, perhaps, Did you have anything in the 2000 range? I don't even narrow it down that much. Recently, pertinent, in the sample, it says pertinent past medical history. So you have to keep it pertinent, just like the people at Walmart. Strangers will tell you all sorts of stuff that you don't need to know. So you ever been in line at Walmart and someone just started telling you stuff? You know, you give them that courtesy look. You don't really want to speak to them. You just sort of give them a courtesy look, and then all of a sudden they tell you, "Oh, don't you hate this weather?" No, I hate you. You know, but so you get, and they start telling you about their life history in the shopping line. Patients are a lot like that. They will give you an abundance of information that you don't need. So, closed-ended questions if you're on my boat. Focus on that chief complaint. Why did you activate EMS? Why did you call? What is wrong the most? What is the pertinent problem that you called for 911 for? You have to sort of say that easily, because if you go up to the patient, they go, "Why do you call 911? See how that sounds? Like, oh, instead of, what's going on today, what is your medical emergency today, or what? So you have to be careful with the patient get offended. Why did you activate EMS? Of course, that's probably what you want to say, when they're complaining of something that doesn't need an ambulance. But be sort of careful there. Focus in on the chief complaint. Remember, the chief complaint is what the patient tells you. Right? And then you go in to the OPQRST. And we've talked about this before, correct? In here? Have we? Okay. These are acronyms like SAMPLE. We've talked about SAMPLE? Not yet? Okay, I'm ahead of myself. So, you have two major acronyms for medical assessment. You have what's called SAMPLE, SAMPLE, right? And then this OPQRST. We'll do the OPQRST first, since it's here. The onset, what were you doing when it started? That's very important, especially if the patient's having chest pain or something like that. What were you doing when this chest pain started? What makes it worse? Provokes it? What makes it worse? Describe the quality of the pain. Is it sharp or is it dull? Is it aching? Feels like a pressure pain? Feels like someone's sitting on you? Does it radiate? Does it move anywhere? Does it move in your arms, your legs, your jaw, back? And then rate the pain on severity 1 to 10. You always tell them 10 being the very worst pain you've ever felt. You have to be sort of careful with that too. I had a guy that got his hand amputated. He looked like he was in pain. This guy was having a heart attack, and he looked like he was in pain. And he rated it on a 3. It's like, I don't want to mess with your numbers here, but you look like you hurt more than a 3. He said, "Well, you said the worst pain I've ever felt. When I got my hand chopped off, that was a lot worse than this." So I had to back up and say, "Well, besides the amputated hand, what would you rate this?" And he goes, "Oh, this is a 10. You take away the hand." So so you sort of have to judge it there. And time on when did this pain start? This is very important, especially with someone having a heart attack. But it's a good step, because in patient assessment, we try to do a systematic approach. And this helps us in our systematic approach to patient assessment. So remember the OPQRST. We'll talk about that a lot more later. But memorize that acronym. And then the other one is the SAMPLE down here. SAMPLE meaning signs and symptoms. On the S, signs and symptoms. What are signs? Something you can see or measure. Symptoms are what the patient has to tell you, like nausea, headache. Those are symptoms. A sign is something you can see or measure. So vital signs, right, would be a sign. Allergies to medication. Everybody has seasonal allergies. This is medication allergies. Are they taking any prescribed medication? And sometimes you have to ask about other medication, over-the-counter. Do they take any over-the-counter medicine? There's that, my favorite, pertinent past medical history, or PMH. Last oral intake, when was the last time you ate? Very important. Always for a diabetic, ask them last time they ate. But as you work down through here, see how systematic it goes? And then you get events leading to the injury or illness. Now these will merge together. You don't have to do OPQRST and sample. Once you sort of get practice with this system, using these two, you can merge these together. So you tell me, and when I'm doing the signs and symptoms, or you're having chest pain, then I start merging that OPQRST in there. Well, when did it start, and what makes it worse? Are you on any medication? Do you have a heart history? Do you have a cardiac history? So those will start to merge. What I recommend is when you come in and practice and do your patient assessment, that you get a piece of paper and you just write sample on it, and then on the other side, OPQRST. As soon as you come in with your blank piece of paper, I recommend writing these down. That way you can refer back and forth and you can take notes. And we'll have plenty of practice on the patient assessment. But the OPQRST and sample, very important acronyms to memorize. So after you sort of learn what's going on with the patient, what their chief complaint is, you start tailoring in your assessment. You don't want to just forget about everything else, but you want to start tailoring in your assessment and working on your assessment and examining the body parts that apply. So if they're having chest pain, you want to listen to the lungs and palpate the chest, right? And if they're having abdominal pain, then you'd want to focus in more on the abdomen than the extremities. Then on pediatrics and geriatrics, both, you might need to, when you're talking with a child, don't hover over the child. It scares the crap out of them. Especially if you're a lot bigger than they are, you're sort of hovering over and they're doing this. So if someone, 6'5" came in here and hovered over me, right? As a, old man trying to get, I'm sick and I'm sitting here and some big paramedic comes in here and 6'5" and hovers over me, I'll be like, get away from me, you're scaring me, I'm going to have a heart attack. Not baby talk in the simple language, but don't use big terms, right? Babies don't even understand baby talk. I don't know why parents and grandparents do that. Talk in the normal language, but use simple language. That's the advantage of going to the Head Start last year's. One of them is to help you communicate with children. So, and you may have to gather, which you probably will, the majority of information from the parents or the caregivers, depending on the circumstance. So once you get your information, once you go through the OPQRST and the sample, I promise you, if you go through this here, it'll make the patient assessments a lot easier. You'll almost pass it just on this alone. So there's a few more things, but this is the majority of the points that you pick up on the OPQRST. And then in sample. So then you just go through, you start sort of your physical exam. I always do this. I always gather the information first, and then the physical exam in medical. So I know what I'm sort of focused on, so what I'm looking at, and then I start in on the physical exam, mainly based on the chief complaint. We'll learn later, we're going to look at a sort of a systematic head-to-toe way of doing this. Always get a set of vital signs, a good set of baseline vitals. We talked about it before. Those give you a base on how your treatment's doing. You can't reassess the patient without a good set of baseline vital signs. So that was on the responsive patient, the patient that could talk to you. The difference here on the unresponsive patient is obviously they're not going to be able to talk to you. You have to get information from bystanders and family, and you'd want to do more of a rapid assessment. So if someone's unconscious, once you do the ABCs and you secure their airway and breathing, and they have a pulse, then you do a rapid physical exam looking for anything that might be life-threatening. And then once you're transporting the patient, then you can go back and do sort of a reassessment. This here is where you would also sort of start to think about advanced life support. Remember, in all of our scenarios, you guys are a BLS, basic life support ambulance. So if you need advanced life support, you're going to have to start thinking about that during this time here. It'll make a lot more sense when we get into all the medical emergencies. You know, a patient having chest pain. You think they're having a heart attack. Do they need ALS? So, yeah, they do. They need drugs. So that you can't give them necessarily. So they do need ALS. So you'd start thinking about that advanced life support during this phase of it here. Do the rapid physical exam like we talked about, head to toe, very similar to the trauma patient, looking for life-threatening events. And this we will get into towards the end here as well, but we'll look at the neck, for jugular vein distension, make sure the trachea is midline, listen for breath sounds, look for those medical alert tags, feel the abdomen. Even with rock hard abs like I have, the abdomen is supposed to be soft and non-tender. So all the belly should be soft and non-tender. You should have pulses and motor function and sensation in the extremities. Check pulse oximetry. And I have a few slides at the end that's going to give us more of a systematic approach to this, to give us the norms. Again, look at that ALS. Do we need ALS? That's something to consider pretty soon. Not that there's ever that many BLS ambulances anymore unless you live in Sunnyvale. But you always want to consider that. That would be something very important, especially for testing purposes. Then, look, you need to obtain the patient's name. That's really important if you go to a trauma center. We'll talk about that again and when we get to trauma. Have to say, hey, what happened? Did you see what happened? Is there a time frame here? Was the patient talking to you before this? Do you know the patient? Do you know if he has any illnesses? Do you know if he's taking any medication? In an unconscious patient, there's a lot of question marks. You can't talk to the patient. A lot of times the family members don't know. But that's all right as long as you get the pertinent information that you need. What do you need in an unconscious patient?
If they're allergic to any medication.
Yeah, you need to know that for sure, because you can't give them any medication. That's happened a gazillion times to me. Unconscious patient, no one knows if they're allergic to anything. I can't give them any medicine. So it gets sort of difficult. Well, can't give them a few medicines. Some medicines, there's no really contraindications to them. But you can't gather that good history that you need. Language is sometimes a barrier. If if no one around you, including, of course, the patient's unconscious, but no one around you speaks English, or speaks what language you speak, so that could be a problem as well. I had a patient I picked up was having a massive heart attack, and he spoke Russian. You ever try to get a Russian interpreter at 3 o'clock in the morning? It's pretty tough. And he not only spoke Russian, but he spoke some weird dialect of it that nobody knew. He didn't speak like common Russian. He spoke some sort of weird dialect. They ended up finally getting a hold of one of his family members, long distance, not in Russia, but on the other side of the United States. And they did the interpreting for them. But this guy was having a massive heart attack, and they couldn't hardly treat him because they didn't know if he had any allergies. And all he was doing is pointing towards his chest. So we gathered, a little charade action there. Something's wrong with your chest. So we just did everything we could for a heart attack. Sure enough, he was having a heart attack. So let's compare these assessments right quick. The primary assessment's pretty much the same. Are they alert? They're responsive. Even in a responsive patient, there might be a life-threatening event taking place. Then you could do a slower history exam. With the responsive medical patient, everything can just be a little bit slower. And that's always good, because if you can slow down a little bit, the less that you might overlook. So pretty much the primary assessment, the ABCs are all the same, but in this unresponsive patient, again, you have a more physical, rapid exam. You need to get a faster set of vital signs than if someone that's conscious. If they're conscious, then you can pretty much know that they have decent set of vital signs, because when you did your ABCs, you got a radial pulse, correct? Well, radial pulse tells you that the patient has at least a systolic pressure of 80. So you know they have somewhat of a decent blood pressure if they have a radial pulse. So the past medical history is a little bit harder. You want to rapid transport this patient because they're unconscious. It's not like the movies. If someone gets knocked unconscious or they become unconscious, when James Bond comes along, Bond knocks him out, and 15 minutes later in the movie, he walks back by, and they're still laying on the floor unconscious. That's a huge thing. The standard of care, if you have 1 minute of unconsciousness, you automatically get a CAT scan. And then a lot of the hospitals, any unconsciousness, you will get a CAT scan. So being unconscious is sort of a big deal, even in medical. Trauma, it's a huge deal. To be knocked out, to be knocked unconscious in a traumatic event is a big deal. It increases the probability of a head injury a lot. So you start thinking about that, and then rapid transport, get that patient to the hospital. In the unresponsive patient, you'll do most of your stuff en route. And that's also on the skill sheet. Down towards the bottom, rapid transport. You'd want to make sure that you verbalize that you don't do rapid transport on the patient. That's one of the critical criteria that will fail you on that skill if you don't.